Dr. Ananth D. Dr. Ananth, he is a senior cataract and refractive surgeon at Lotus Eye Hospital, Coimbatore. He is going to talk on dry eyes and cataract surgery.
So, good morning everyone, and thank you Sirish sir for including me in this topic. After listening to all surgical challenging cases, it's a cold case, medical case each and every day. All these cases you will see once in a week, but my topic, each and every patient, either you may be exaggerating the dry eye or you may be forgetting about the dry eye and doing the cataract surgery. So, we do perform the cataract surgery very successfully, but if at all, if dry eye is forgotten or if it is neglected or if it's exaggerated, the quality of life is affected to the patient keeps coming repeatedly to us, it can have a double-edged effect affecting our name and the hospital brand also. So we know dry eye is a chronic disease. It's much more prevalent in the age group between 50 to 70. Females do suffer more. And as I mentioned, cataract surgery can be iatrogenic also. It can exaggerate also. We can see the significant reduction in Simmers, T-but, and tear meniscal height. Even in non-dry eye group also, dry eye symptoms do appear. The triad of dry eye, the tear film instability, hyperosmolarity, and inflammatory mediators, release of cytokines, interleukins, stays. The end target is the apoptotic death of the surface cells. And added to this, cataract patients can have physiological decrease in the tear film. When this topic was given to me by Dr. Shirish Kumar in my busy schedule, I thought I should speak on cataract surgery induced dry eye. But after looking to the program book only, I understood that I have to speak on the topic where I have to do cataract in a dry eye patient. So I had to change my topic just 3 days back. This same thing happens whenever we are handling the cataract surgery patients also. We are paying attention to his reduced vision, planning about the type of surgery, type of IOL, but we tend to forget these symptoms. Each and every symptom has to be paid attention, whatever busy we are. Otherwise, we are going to suffer or we are make the patient suffer. As such, dry eye has got a huge impact on the cataract surgery. First, coming to optical biometry, you need to have a stable tear film. It is known that if the tear film is not stable, it is almost going to affect the keratometry value by 1.3, which has a significant effect on biometry and our IOL calculations. In our institution, we do invasive, non-invasive, both T-but before cataract surgery, because majority of the patients are premium IOL patients. And it is also documented that hyperosmolarity, when it increases, normal is 304 to 308, it increases, it has got a significant values on keratometric values. And we never want a patient to have a fluctuating vision in a premium IOL sector patients, either trifocal or multifocal patients. Dry eye induced aberrations can bring about fluctuating vision, so we need to stabilize the tear film and then go ahead with the cataract surgery. Evaluation, the basic questionnaire you should have, invasive or non-invasive T-but test is mandatory. If in doubt, please stain and Shimmers test is mandatory before. This chart alone explains each and every modification which we need to have in our own practice. Preoperatively, we might have seen sisters are not aware. We need to educate them about the precocious use of anesthetics. Sometimes we are doing topical surgery, patient not cooperative. The tendency is to put 4 or 5 drops of topical anesthesia. We need to make sure that not more than 1 or 2 drops. Sometimes mydriatics do induce blepharitis and bring about surface inflammation also. BAK, even 0.001% can bring about epithelial toxicity. Intraoperatively, short surgical time is always better. Long surgical time, phototoxicity, release of interleukins, it can bring about the damage. We are putting a speculum. There can be a tear deficiency. The pupil is dilated. The defense mechanism of blinking and meiosis are not there. So this has to be taken care, quick surgery. And the corneal incision usually doesn't matter, superior or temporal. And most of the times we are doing the temporal phacosis of 2.8. The transaction which happens is very, very minimal. But whenever we land up in an eventful surgery or extending the wound or you are irritating too much, there can be anesthesia of the stromal plexus of nerves where you have done the transaction. And it almost takes around 1 month for the nerve to regenerate. Lid speculum, again, it can express the mucobin glands. There can be alteration of congruity of the dynamics between the lid and ocular surface that can alter the tear film. Post-operatively, preserved antibiotic for a long time can bring about the surface damage. Antibiotic should be restricted only for 5 days. Some NSAIDs do bring about epithelial toxicity. So how to avoid, as I told, educate the sisters to use anesthesia only once or twice prior to surgery. And intracameral adrenaline, we have this fusion, it can be used and shorten the surgical time. And these days, we are doing more number of femto cataracts. Femto, whenever we are placing a femto ring, it's a scleral-based ring. That itself can bring about a global cell damage, conjunctival hyperemia, inflammatory edema can be there. So we should be precautious while doing femto-based cataract surgery in already patient having a dry eye. And one more important thing is persistent surface irrigation has to be prevented, so we can put viscoelastic devices over the cornea and continue with our surgeries. And antibiotic should be limited only to 5 days, precautious use of NSAIDs. Coming on to the, and we should also pay attention to the associated comorbidities, patients, hypertensives, diabetic, autoimmune people, Parkinsonism, we are on multiple systemic drug, we can exaggerate the dry eye in these patients. Diabetic patient, diabetic capital is our country, so we need to understand that diabetic patients are more prone to suffer from dry eye. Lifestyle modification has to be advised to the patients. This has to be kept in mind. And each and every cataract surgeon is a master in handling the dry eye patients, because we need to get away with the patients because of these complaints. Multiple drugs are available, but in my personal choice, I would like to use CMC 0.5 or 1% for all the patients who have exaggerated dry eye symptoms. Thank you.
Thank you, Ananth. It was a wonderful, it's a comprehensive coverage of the topic. We do a dry eye workup for almost all the cases of cataract and refractive surgery patients. Dr. Rajesh, do you do it routinely for all your cases?
Not the whole of, not 100% of cases.
And refractive?
But if, in refractive, yes, 100% of cases. But when we are doing cataract surgery, we see if the patient, we have to be, we are a little selective in that, not in all cases. If the patient has any of the symptoms, if the lid margin showing some MGD, etc., if there is some degree of, subtle surface inflammation, or the patient has some complaints. Some patients do complain that, the patient has less vision but still complains that I'm having watering, I'm having itching. So those patients do require the detailed investigation. But there are some patients whose ocular surface is absolutely clean, shining, everything good. Patient has complaints of blurring of vision, only has a cataract which is commensurate with that. Then in that case, we don't do.
Dr. Shirish, I think one simple thing which we do is we do what is called ocular surface stress test.
Okay.
At the end of the day, when the patient goes through all the procedures, contact, non-contact, topical dilatation drops, and when they come and if you see any staining on the cornea, that means these patients are prone for not the 80 mark, but the surface staining. That is the patient where we need to take a extra precaution.
One question to you, Dr. Sudhir. Like if the patient comes for a workup for cataract surgery and you detect severe dryness, that is Schirmer's 0, 1, and T-Wet also like 1 or 2, and your lipid layer thickness is also less, around 30 nanometers. So in such cases, like how long you will wait? You will treat them immediately, or how is it?
Yeah, we have to treat them. I think these patients will do well with cautery, the punctal cautery, or for plugs. Yeah, at least give a trial of plugs and see how they do well. And maybe these are severe patients, may need a cauterization of the puncta. But and once you have the...
With that, you go ahead and do the surgery immediately, or
not
you will
immediately.
wait for some time?
Wait for some time on the surface.
How long you will wait? Or
usually
you
2-3 minimum.
Improve the surface?
Yes. Yeah, because your DBR, everything will change. So you have to wait until the... Yeah.
Any comment on lipid flow? Do you
Yeah.
take do you rule out all the systemic diseases?
Yes, sir. Yes, sir. The severe dry eye, we do the entire workup.
Yeah.
Even the rheumatologist workup is very important in these cases. And then We have to wait them for at least a month.
Yes.
Once it stabilizes, then go ahead with the surgery.
Thank you. We have come to the end of the session, and I thank all my co-panelists, all the speakers, and all the audience for their wonderful participation.